Hello, everyone. Today we're going to be discussing part of the FACETS curriculum in dealing with pressure ulcers. And today I'm Thomas Horton, one of the PGY3s in internal medicine here at Vanderbilt. And accompanying us, we have Dr. Duggan, Mari Duggan, who's the program director for the Geriatrics Fellowship Program here, and then intern at Vanderbilt, Mallory Bryant. So we're really excited to learn about this today. So Dr. Duggan, when you think about framing pressure ulcers and pressure injuries, I should say, how do you usually, what's your framework and approach when you're seeing patients here in the hospital in patient setting?
Yeah, so great question. So I'm glad you caught it. Pressure injuries, not pressure ulcers, right?
Exactly.
Yeah, and so that was bright of you. That change happened a few years ago or so in terms of the verbiage, right? Because pressure ulcers aren't necessarily ulcerated parts of the skin, right? We can have a pressure ulcer that just started and it's on the superficial portion of the skin. And so it just appears flat and red, but it's covered and it's not really ulcerated. And yet the blood flow is reduced as you press down, that skin does not blanch. And so we know that that's a stage 1 pressure ulcer. So I think in terms of the approach, you want to think about screening and prevention. So the best approach to pressure ulcers is to prevent them from ever happening. And then once you do detect that there are pressure ulcers, what can we do to promote healing in that area? So those are kind of the two big buckets that I think of when I think of pressure injuries. Have you all seen many pressure injuries on service in the hospital?
Unfortunately, yes. Unfortunately, yes. And I always try to remember what are some of the locations on the body where we might look for these injuries.
Yeah, absolutely. So, we commonly think of the sacrum as an area where there is pressure, and we often see sacral pressure injuries. And other places that maybe we don't think of all the time are the greater trochanter, the heels, and sometimes even the back of the head in patients who are supine for very long periods of time, between the knees as well. So for patients who are immobile, yes, you think about the sacrum, but also don't forget that there's other places in the body where there will be pressure build up because people are not moving around.
Absolutely. And I love your framework. Prevention obviously is key. What are some of the things we can do to hopefully prevent some of our patients developing these injuries as they stay with us in the hospital?
Yeah, absolutely. So I think of, I'm not very smart, so I have to make everything be like an acronym or like 5 or 6 M's. We like the 4 M's, 5 M's in geriatrics. So I think of the M's being moisture. So as we have a pressure, a risk of a pressure injury in a patient, that risk is going to come when the skin is too dry or too wet. And so frequent urinary incontinence can increase the risk of pressure injuries in the sacral area. Dry heels also will increase that risk of pressure injury, for example. And so if it's wet, you want to dry it or put a barrier cream there. And if it's dry, you want to wet it or put an ointment there to keep the skin moist. So that's moisture. Mobilization is the second M. So get that person off their backside, get them up, get them standing and walking as much as is possible. So the third M, mattress. If patients are high risk for developing a pressure injury, we like to have our nurses help us coordinate getting a mattress, a specialty mattress specifically designed to offload certain areas. It doesn't have to be one of those fancy air mattresses, although I think those are helpful if you're sort of more advanced in the staging of the pressure injuries.
For sure.
So, moisture, mobility, mattress, mechanical loading. So this is where, you're turning every couple hours comes in to reduce that pressure. And it's not just pressure that can cause injuries. We also, as we pull patients up in bed, sometimes that shear, that friction can cause damage to the skin. And so using, for example, a draw sheet under the patient to slide them up in bed is sort of recommended to avoid that injury. And then the fifth M is meals or maintaining optimal nutrition. So these approaches kind of target some of those risk factors that can be present and can increase the risk of developing a pressure injury among our older adults.
Definitely. Yeah, I always I've become more cognizant as I've gone through training to definitely look at how often our patients are being turned, because our nursing staff is extremely busy. So just on rounds, it's really cognizant. I've become more cognizant about, asking those questions. And then even too, if you're in there, if we're as a team, they're ourselves able to do that and kind of help spread the work just for the betterment of the patient, which has been really helpful. So
yeah, absolutely. We can.
Go ahead, Dr.
Mallory, like I was going to say, like, you don't get training in how to turn somebody appropriately who has a pressure injury. Mallory, you've had great education throughout your career and you're a PGY1, almost a PGY2. Have you received formal training in how to turn a patient that has, say, a sacral pressure injury?
Yeah, I haven't received any, and I think most of my peers would agree with me. And I think a lot of us are happy to help, but we just haven't received that training and are, I think, afraid of causing harm or making a problem worse. When really, like, a quick demonstration or chatting with the bedside nurse and saying, hey, I would love to help you with this, whenever I'm here in the room, could be really helpful.
Absolutely. Yeah. The nursing staff has tons of tips and tricks. I never learned it in my medical training, but just learned it on the job in working with the nursing staff. It's a good skill.
Definitely. And then, so let's say we've identified some of these areas that have developed pressure injuries, or the patients, when they're admitted to us, already have these injuries. What are some of the things we can do to help treat these things, Dr. Duggan?
Yeah. So there are plentiful options for treating pressure injuries. And everyone kind of thinks about dressings and sort of creams or medications. But I think we need to take a step back and really address those risk factors that we talked about before. So a lot of the treatment is those M's of prevention, right? So mobilizing the patient, getting them out of bed, making sure we have a good mattress, working on preventing shear friction injury, which might worsen an ulcer, and nutrition, right? And then when it comes to the actual wound, I'm not a wound certified geriatrician like some of us are, and I'm not a wound nurse practitioner or a plastic surgeon. So in my basic world, I sort of think of stage 1 and 2 similarly, and stage 3 and 4 approached a little bit differently. So stage 1, right, where it's just non-blanching erythema, and stage 2, where the epidermis is open and we have an actual sore or an ulcer there, stage 2, we usually can treat those with dressings like a foam dressing, for example. It can be really helpful just to help healing of that ulcer. Stage 3 and 4, I usually will have our wound nurse practitioner come and make recommendations on the dressing. There are dressings that reduce bacterial load. There are dressings that are absorbent versus non-absorbent, right? So depending on how much drainage there is in the wound, and sometimes these wounds have to be debrided as well at the bedside, and that's something that our specialists can help us with. Our nursing staff are fantastic at looking for pressure injuries every day, identifying them and treating, those stage 1s and 2s where appropriate. So that's my basic approach.
Yeah, and I have developed a low threshold just to get our wound care specialists involved, even if I'm questioning, stage 2 versus stage 3, just so we can better optimize the wound care moving forward as soon as we identify the injury. And especially too, it helps our nursing staff, our bedside nurses, because they get recommendations or are able to act on those a little bit more frequently than our consultants would be.
Absolutely.
Well, so helpful. And I know it's something that unfortunately we have to deal with on a day-to-day basis, especially in the geriatric population. Dr. Duggan, are there any other pearls or things that you've picked up on as your time as a geriatrics fellow and attending over the past few years?
Yeah, I think the most important thing is to know that, common sense, immobility can lead to pressure injuries. And when we go down to the ER to admit somebody and they're in a stretcher, it's been 4 hours or 8 hours or 12 hours that they've been down there. EDs are not always well equipped to promote mobility and get patients out of bed and walk them. And so just being very attuned when you admit a patient to making sure you've turned and looked at the backside, looked along the spine, the back of the head. And again, if they're at very high risk because of severe malnutrition or immobility, making sure you check those areas on the hip, on the insides of the knees, on the heels as well, just so that you don't miss anything, because delay in recognition certainly doesn't help with healing these ulcers faster. And so I think detection, once you detect it and find it, that is probably the most important step, right? Because you always have consultants that once you know those wounds are there, you can reach out to those people for help. Our nurses are great, but they may miss ulcers, so we always want to be attuned to those.
Definitely. And I think it also depends on where our patients are in the hospital. So not everybody is going to be on the ACE unit for where nurses and our even ancillary staff are, very well tuned to our patient population's kind of special needs. So if you have a patient boarded in the ED or different places around the hospital, it's even more important for us as the physicians to kind of identify those areas. Definitely agree.
Absolutely. Thanks, Thomas. This was fun.
Absolutely. Well, thank you all so much for joining us, and we look forward to discussing more of the FACETS curriculum here in video format and other topics soon. Thanks.